How's it going, guys? We have a pass level question for steps 1 through 3. 54-year-old woman, 7-month history, progressively worsening pain in her left hip. Pain is worse when she walks around the grocery store and the shopping street nearby her home. Otherwise, she spends most of the day at home watching TV and there's less pain during this time. She has been smoking 1 pack of cigarettes daily for 30 years, drinks 2 glasses of wine with dinner every evening. She's 5'2", 180 pounds. Her HbA1c is 7.0. 6.5 or greater is diabetes mellitus. Physical examination shows 5 out of 5 strength in all 4 extremities, with slight pain elicited in the left hip on passive active motion. She uses acetaminophen and ibuprofen to manage the pain, where the combination works to a moderate degree. Her vitals are normal except for an elevated blood pressure, 150 on 90. Which of the following is most likely to have prevented this patient's condition? Choice A, alcohol cessation, is wrong. So, alcohol, obviously, for alcoholic hepatitis, liver disease, there should be no more than 1 to 2 standard drinks per day. Okay, so for women, usually no more than 1 per day. For men, no more than 2 per day. The literature is debated on the benefit, quote unquote, of alcohol. Okay, so some literature says that it actually improves cardiovascular health. It was actually on an old free 120 where you need to know alcohol increases HDL. We do not advise patients to start drinking alcohol if they don't already, because from an epidemiological perspective, most people are going to drink too much and they're going to abuse it. Okay, so 1 beer could be 1.5 drinks as an example. And so that's more than someone should even have. So it's a very small amount. However, if somebody drinks a very small amount of alcohol responsibly, we can tell them it's okay to continue drinking, that it's not that they have to quit it. Wrong fucking answer. Choice B, blood pressure management, is wrong. So the most important thing regarding blood pressure for USMLE is stroke risk. So when we talk about atherosclerosis, the most important, the most acceleratory risk factors are: number 1, diabetes, then smoking, then hypertension. Hypertension is most common in the population overall, but diabetes, then smoking, then hypertension are most acceleratory in descending order. However, when we talk about the carotids specifically, hypertension is the most acceleratory risk factor. Okay, so when we deal with the coronaries, the popliteals, the abdominal aorta, the renal arteries, the vertebral arteries, all of that is diabetes, then smoking, then hypertension. But the carotids, it's hypertension. And this is because the systolic impulse close to the heart is going to pound those carotids, causing endothelial damage, leading to atheromatosis development, where one of those cholesterol plaques will launch off to the brain/eye, causing stroke, TIA, retinal artery occlusion. So for USMLE, blood pressure management, it's not the case here, but I'm just giving you the important info. Blood pressure management is most important for reducing the risk of stroke, not smoking cessation if they list both, even though a patient obviously should not smoke. Okay, and weight loss is the number 1 way to reduce blood pressure in terms of lifestyle modification, more than smoking cessation. So if a patient's overweight, they have hypertension, they should lose weight. Okay, that's the most important thing. Wrong fucking answer. Choice C, glycemic control, is wrong. So diabetes, of course, we just said it's most acceleratory for atherosclerosis. Diabetes in general. Every patient with diabetes is going to develop glomerulosclerosis with nephrotic syndrome, retinopathy, peripheral neuropathy, gastroparesis, overflow incontinence, neurogenic bladder. It's just a matter of when. If they have excellent glycemic control, maybe they won't get that stuff until they're in their 90s. They live a normal life. But if they have poor glycemic control, okay, maybe they'll get it in their 40s or their 50s, right? So glycemic control is important. And of course, atherosclerosis, most important. It's the most common cause of death in MI because of, most common cause of death in diabetes, MI, because of the reasons we just discussed with atherosclerotic development. Wrong fucking answer. Choice D, reduced calorie diet, correct answer. Patient has very past level presentation for osteoarthritis. So it's usually, there's two demographics. The first is patients generally over the age of 50 who are overweight. Now, we don't have to calculate her BMI here because she's 5'2" and 180 pounds. That's clearly very heavy. All right. And we're talking about the hip. So our first demographic is overweight people who have hip and knee pain, and it's usually asymmetric in contrast to RA, which is symmetric. And RA is also 20s to 30s, but up to 50s. Point is OA 50 plus usually, RA 20s, 30s. RA symmetric, OA asymmetric. OA non-inflammatory, so your ESR is normal, almost always. CRP normal. Okay, no low-grade fevers with autoimmune flares, none of that stuff. Morning stiffness not reliable. You can sometimes have that with OA, even though it's classically longer with RA. Okay, so that's your first demographic, overweight people, hips and knees. Sort of a 1.5 demographic is big and tall. So there's a question on one of the NBMEs where they give you a 32-year-old woman who has a BMI of 30 and she's 6'2". It's a little bit unusual, but occasionally you can have slightly big and tall people. Okay, I don't know if slightly is the word to use with that, but you can have big and tall people where they're not morbidly obese. Okay, because classically you'll get someone who's 60 years old with a BMI of 40, and that's OA, but you can also have slightly younger in their 30s, big and tall. That can be OA. Your second demographic is going to be the hands, and the patient does not have to be overweight. It can be a mechanic, it can be someone who, an old lady who knits a lot with their hands. Okay, you get DIP involvement. So those are your two major groups for OA, but weight loss is what they want if it's listed for OA for most patients. Okay, and acetaminophen NSAID is how we treat. If that stuff doesn't work, you can try other modalities such as corticosteroid injection. Okay, it's probably mostly a placebo because we said it's not inflammatory, but it shows up on a 2CK form as more of a last resort before you go to surgery. Let's go to the final one. Smoke cessation is wrong. So as we already talked about, that is not as important for stroke as hypertension is. There was a question on one of the 2CK forms where the patient is both a smoker and has hypertension, and they're asking about MI risk, and it was smoking cessation was more important. These questions are nuanced because you have to use your fucking head, okay? What do I mean by that? If you get a 10-line paragraph and 9 of the lines are about how bad the hypertension is, 180 over 100, the whole vignette's about hypertension, and they're coincidentally a smoker, obviously they're pushing hypertension on you. You understand? But in general, if you just have a vignette overall where they're not emphasizing one over the other, they want the smoking over the hypertension. And then smoking, of course, just for basically every cancer, not just lung. Okay. Wrong fucking answer.